This is Dr. Ravi Kamapali. I'm going to be talking at APWCA later tomorrow, and I just decided to record this video and wanted to share it in detail as there might be some time restriction on the APWCA recording. So the topic is about anti-inflammatory diets and wound healing. And basically, I'm located in Georgia, and my Twitter handle is at Wound Physician, and I am targeting tsunami of chronic diseases, and hashtag that I mostly use is removing barriers to healing. So my interest in this whole process is not anything except for food as medicine approach, and I don't have much of any conflicts of interest except for the above few investments that I made, but not related to this topic. The objective of today's talk is to take an overview of nutrition, quick data issues, and also acknowledge the current evidence on remission of type 2 diabetes and the position of International Organization on Carbohydrate Restriction and Management of Diabetes, and discuss the key components of well-formulated carbohydrate restricted dietary approach and results review of current gaps in knowledge and using how can we come up with interdisciplinary approach with a food first approach with n equal to 1 methods of delivery of solutions and role of nutritional ketosis in wound healing. So this is a case of a 83-year-old male who was sent to me for evaluation after a patient has been noted to have necrotic toes and problems with swelling in the legs and significant venous insufficiency on the top of his problems with congestive heart failure. And he had PTCA done on 3/4/2021 and high-grade stenosis that was taken care of with atherectomy and balloon angioplasty. And his creatinine was also elevated at 1.6, and his overall weight issues were significant, with his weight being 225 pounds. But we ended up doing standard of care, including debridement and wound care and antibiotic therapy. But the key thing for this gentleman was advice that we discussed, and the patient strictly followed with his wife, and his weight came down to 181 pounds. And overall, if you see, the creatinine also improved. So basically, we used therapeutic carbohydrate restriction along with wound care. So the idea is we need to do combined modality approach in healing. So this brings us to the data of sobering data that 34 million cases of diabetics in US, with significantly 88 million people having pre-diabetes, and it causes around 130,000 non-traumatic amputations annually, and 58,000 people are getting onto dialysis, with diabetes people dying 6 years earlier than people without diabetes. Now, the cost, as you know, is direct cost is heavy, with $237 billion in 2017, and it was only $80 billion for cancer in 2015. So the comparison is huge. And also, one third of direct costs of this diabetes are related to the amputation of lower extremities. So it just comes down to compare breast cancer and the lower extremity amputations as a mortality rate. If you see here, it's only 9% for breast cancer rate for 5-year mortality rate, whereas even with minor amputation, the breast the leg the mortality rate is 46.2%, and obviously with major amputation it is 56.6%. 5-year mortality rate, whereas it only is beaten by lung cancer as a mortality rate. So the care is kind of challenging with a diabetic foot. We don't do much of primary prevention, and that too primary prevention of diabetes is not being done. Then it comes down to secondary prevention of reducing new ulcer formation and improving long-term survival, and also other factors including continued trauma, infection, peripheral vascular disease, neuropathies, and abnormal wound biologies that have to be dealt with are not being addressed. And there are multiple factors, including patient factors and comorbidities that are related to non-adherence. So wound care is challenging given that it is done in multiple settings, multiple caregivers, multiple comorbidities, and also multiple specialities. So it just comes down to us trying to figure out how we can effectively help patients prolong their life and reduce amputation, and we have to come up with new strategies to do that. So we know that the major pillars of wound healing are these four: coagulation, inflammation, and migration and proliferation. I don't want to go into details of that, and there are other presentations that people who have come to this conference can look into for that. But major threats are aging. We know that aging is a huge factor. Extremes of aging can cause healing issues, but in major problem is increased reactive oxygen species, and as we know, the wound remodeling occurs after inflammation, and basically there is increased reactive oxygen species, and this is created because of respiratory burst that is intended to kill harmful bacteria. But when there is increased reactive oxygen species, there is inflammation, and basically that increases the chronicity. Obviously, there is other issues including deficient metabolism, wherein the ATP production for repair is not happening, and metabolically there is nutrient deficiencies that contribute to that, and there is energy issues that might factor in. The other factor is insufficient blood flow that leads to hypoxia. And we're going to talk about chronic inflammation and how nutrition can change in this with chronic inflammation. Obviously, nutrition is a huge aspect in inflammation. And we're not going to talk about infection and biofilm, which is another huge aspect in wound healing. So coming to the nutrition aspect, simply ignoring nutrition is not a good idea, and wound healing would be neglected if we would be a problem if we have neglect the powerful tool. I'm not going to discuss deep into the vitamins here and even the amino acids. We know that macronutrients, carbohydrates, protein, and fat are involved, but also the major thing that I want to focus is on carbohydrates. We focus and treat and tell people to eat calories, but we need to know and understand that carbohydrates have a problem creating issue wherein they stimulate insulin, which plays a huge role in inflammation. And we need to understand nutrition, but also understand what the role insulin plays. But we have to understand also calorie restriction might be a huge issue in wound healing, but kind of calories are also going to be important. So we'll talk on that. Now, this was a UKPDS study where they showed that 1% reduction of hemoglobin A1C is associated with long-term complications of 16% heart failure. But if you see the fatality rate, because there is 43% improvement if we reduce this hemoglobin A1C, the impact on the microvascular diseases are larger with hemoglobin A1C reduction than when compared to the macrovascular diseases. So that is something important that has to be taken away from that study. Another study, that DCCT study, wherein they showed type 1 diabetics, intensive control of blood sugar was very much shown to improve the incidence of foot ulcers in type 1 diabetics. We'll discuss on that. The intensive control of sugar with insulin use in this type 1 diabetics helped, but also do we need to use insulin in other situations, or is there any way in which we can reduce the insulin use? That's we can discuss. So inflammation is at the heart of everything of the modern diseases, and medical science has mostly failed because we are doing read, repeat, and reward. That is, we're getting money for what we are reading, and we are taking care of things. And the question is there a problem? Is there going to be punishment because the outcomes are not as we want them to be? And inflammation is caused by recurrent excessive refined carbohydrate use, including fructose and polyols. And where did we miss this whole problem? Where did modern medicine miss it? I think it's a pathology and biochemistry of how fructose, refined fats, and polysaturated oils connect this whole process to inflammation. So humans are hormonally driven, and we have been modified over centuries because of the hormones that we have. And over time, we have gained more energy, and that energy is in the form of fat. And basically, if you see, when we over time, whatever we eat has to be converted into an energy form for storage. And carbohydrates, when eaten, the blood sugar spikes 100%, protein 40%, and fat, when eaten, only 4% spike in blood sugar. So that initiates the insulin spike. We need to understand that for diabetes to occur, or for any problem to happen with this in this scenario, if you see, the blood sugars are always maintained low. Why? Because the insulin secretion is high. And until insulin secretion falls, that's when the blood sugar goes up. That's when the insulin resistance happen, or the significant loss of beta cell mass happens. Until then, you're kind of, quote said, you're pre-diabetic. But it's a spectrum disease anyway. So the progression of microvascular and macrovascular diseases is very significant. We need to understand that the microvascular diseases happen long before the frank diabetes happens. So obviously, it takes almost decades for this to happen. This was shown in diabetes care. So what is insulin resistance? It's a subnormal glucose response to endogenous or exogenous insulin. The causes of this are obesity and nutritionally associated, and other issues include stress, excess counter-regulatory hormones that can cause because of stress, or growth hormones, or catecholamines, and obviously in medications, including glucocorticoids, HIV medication, oral contraceptives, and there are and also insulin antibodies, and genetic conditions are also autoantibodies are also there with type B insulin resistance. Now, in pregnancy and puberty are two physiological insulin resistant states. So this insulin resistance is the most common cause of blood sugar upheavals and hormonal balances. So the spectrum where when the insulin is low is best needed for metabolic outcomes, and we need to start testing fasting insulin more often. So what is the timeline of this whole problem is we need to understand that even in early 1700s and 1800s, the ketones have been ketogenic nutrition has been the baseline of all nutritional therapy, and therapeutic carbohydrate restriction, as I would like to call that, instead of ketogenic. Basically, ketones were discovered in 1850, and then in 1920s, the insulin was invented, and then things changed in nutritional ketosis was more proven with the Cahill studies, fasting studies, and then Atkins diet came, then keto adaptation happened, and then everything was a problem since nutritional recommendation, dietary recommendations happened in 70s, and over the time, the whole industry produced foods, and then that caused changes, and early 2000s is when the ketogenic diet started surging. But if as per this report, this is a carbohydrate restriction for diabetes is a rediscovering the centuries old wisdom, wherein it was already it really shown that carbohydrate restriction in long before urine. If you see here, even in 1920s, or it was first reported for diabetes, but then the insulin was invented, and then obviously multiple insulin inventions happened, and now the medical nutritional therapy, then emphasis on pharmacotherapy happened. So basically, we need to understand that carbohydrate restriction was used for in 1700s to prolong survival. Then once insulin was invented, it fell out of favor. But if you notice here, carbohydrates, this use of high fat diet in treatment of diabetes. This was a study in the journal that was published in early 1920s. So obviously, we have forgotten something. So we need to relearn what we forgot, and we need to understand that the definition of what is a carbohydrate, what is a well-formulated carbohydrate, ketogenic nutrition. So when we have carbohydrate restriction of less than 25% or less than 50 grams of carbs per day, then it is low carb. Less than 10%, that is 0 to 50 grams of carbs, it is ketogenic. And 26 to 45, it's moderate carb. So any study that has claims to be ketogenic low carb and that has more than 25% is not really a ketogenic study. So that's where we have to be critical. So obviously, sad American diet falls in where the carbohydrates percent is more than 50%. And we need to understand that nutritional ketosis is not ketoacidosis, and wherein the body is adapting to the ketones. And once the body fat adaptation happens, when you're in nutritional ketosis over consecutive weeks, that's when the full spectrum of benefits happen. So nutritional ketosis is when ketones are from zero point 0.5 till 3, and when it goes into 5, the ketone levels go into more than 5, then the starvation ketosis. But then ketoacidosis happens when the ketone levels are more than 10. So that is where we have to be understanding this whole problem. So basically, why does this happen is the key. We have to understand this whole issue because number one, we eat fed. We are mostly fed in a fed state. We need to understand that the food we eat is going to be converted into energy. The carbohydrates go through glycolysis, fats go through beta oxidation, and amino acids go to transamination. But all of these pathways end up in a common molecule called acetyl-CoA, and that acetyl-CoA goes into Krebs cycle. Now, in the Krebs cycle, the result of Krebs cycle is acetoacetate. What happens with in a carb restricted state is that then the body wants to produce glucose, and so it steals away for gluconeogenesis. The acetoacetate is taken away. Then when the acetoacetate is taken away, there is a lot of acetyl-CoA left. Now, in the body, there is mitochondria, that is a powerhouse of the cell. But the mitochondria that are present only in the liver are capable of converting the acetyl-CoA into beta-hydroxybutyrate through acetoacetate pathway. So acetoacetate, beta-hydroxybutyrate, and acetone are the three molecules of ketones that are kind of produced through this pathway with enzymes that are available only in the mitochondria. So we have to understand that the role of ketones are not only just as a fuel, but also it has significant signaling properties. Whereas it is being used now, all the cancer treatments of that histone deacetylase inhibitors. These ketones are a histone deacetylase inhibitors. We need to understand that once the acetoacetate is produced, it is easily converted into beta hydroxybutyrate, which is a very important molecule that is in the blood, and that controls the genetic expression of the genes as an epigenetic factor. So, and then that is also released as acetone, which we breathe out. And all these acetone is spontaneously released also from acetoacetate. So these are the three molecules, and hopefully that is clear as to understanding the basics of why this is important. So the basics are that it occurs, the nutritional ketosis occurs when dietary carbohydrates are limited and dietary protein is moderate. Then ketosis occurs during fasting too, and nutritional ketosis is not diabetic ketoacidosis. So we have to understand that nutritional ketosis to happen, the insulin levels have to be low, and you do not have to be in nutritional ketosis for benefits of the this whole process. So it is important for us to make sure that we take protein for wound healing, but we have to understand that also for ketogenic lifestyle, this we are carrying a lot of energy, but this energy we are hauling around, but we are using carbohydrate, whereas the whole fat energy is there. And this whole process can only happen when the tap of carbohydrate intake is turned off. Now, why should we do that? Is because if we have carbohydrates, then the sugar is in the blood, and then the sugars impair neutrophils and prevention of engulfing of the bacteria. And the glycation that happens causes problems with the production of methyl glyoxal, which kind of is affecting the natural killer cells and causing more problems with glycation. So the the glucose in the blood is a rigid molecule. It lines the molecule. It lines the epithelial cells and nerves, and causes inflammation, endothelial dysfunction, and obviously atherosclerosis and peripheral vascular disease. The more the glucose, more the glycation and production. With fructose, it is 7 times more complex. I'll go rapidly because of the time, but we have to understand that Western diets trigger NLRP3 inflammasome. This is a this NLRP3 is a complex protein molecule that is directed by that has a gene on chromosome 1 that is stimulated with the Western diet. And obviously, this is a mouse model where Western diets alter the lipoprotein responses and mediates the inflammation, causing the whole granulocytes, causing more inflammation because of the dietary lifestyle and the Western style living. So this increases, these problems are initiated also through the reactive oxygen species that mediate the problems, including via the Th17 cells of the T cell path, Th17 cells that high glucose induce that. Now, ketones are very, very necessary and good molecules for the pathway. They act like drugs. And even in aging, basically, beta hydroxybutyrate is noted to show effect against histone deacetylase inhibitors. It is similar to powerful drugs that are used in cancer. And obviously, beta hydroxybutyrate is involved in gene expression. So this was one of the first studies that I like about ketogenic nutrition, and this was done by Don D'Agostino. And exogenous ketone supplementation was noted to show improvement in wound healing via advanced migration, reducing reactive oxygen species, and resolving inflammation. And obviously, they suggested that ketone supplementation may suppress inflammation, and pro-inflammatory markers are reduced. So this is another ketogenic diet in infection. So I'm an infectious disease doctor, and mycobacterium is a huge thing for infectious disease. And we need to understand that this bacillus, this is a mouse model where the bacillus produce mycolactone, and basically they use beta hydroxybutyrate that controls this mycolactone production. So this is another important thing. This was a study done recently in 21. They came up with a molecule. It was published in JAMA, and this molecule is 101 exhibited increased M2 macrophages that improve the inflammatory, having an anti-inflammatory function. So M1 macrophages are pro-inflammatory. And we need to understand that in insulin resistance, there is increased M1. So M2 is what we need for wound healing also. So basically, if you see here, skin and normal macrophage function during the early stages, there is M1 macrophages that is pro-inflammatory. And in people with diabetes, the macrophage numbers are altered and not able to switch to M2 macrophages. That's a huge problem. So here, this histone DS basically inhibition is happening with the ketogenic nutrition, and obviously in type 2 diabetics, these factors are controlled by epigenetic changes that are happening. So bone marrow, this was a bone marrow study in humans where activated M1 macrophages are known to play a huge role. And basically, insulin resistant hyperglycemic environment result in epigenetic changes in bone marrow that persist in peripheral wounds. And obviously, bone marrow changes also happen because of elevated glucose. So similarly, we talk a lot about MMPs in wound healing, but also here we need to understand that in atherosclerosis also MMP2 plays a huge role. Platelets have MMP2 activated platelets, then that increases the atherosclerosis. So we are playing this game of medicine. This is the end game of medicine where the lipodystrophy or fat mass disease is causing a huge problem with complications that end organ damage that are being seen by all the atherogenic issues. So but also we have to understand that there's one other silent pathway that nobody really talks about. It's called sorbitol pathway, wherein the glucose is converted to sorbitol because of aldose reductase, and then in the eye, kidney, and nerve, it is not converted back into fructose, or it is not changed into fructose. But the problem is when the sorbitol is formed, then there is significant issue with increasing reactive oxygen species are activated end products of glycation, and receptors for activated end products of glycation are also stimulated. The problem is that the aldose reductase concentration is increased if there is increased glucose also. So sorbitol pathway is a huge pathway. You don't need to, if fructose by itself is bad, but large amount of glucose intake makes it get converted into fructose. So we need to understand what we're doing and the silent disasters that are happening. So nutrition and low carb therapeutic carbohydrate restriction evidence is increasing remarkably. If you want to research more, you can check Public Health Corporation UK .org, this website. Please note down if you want to. And there's multiple studies that are going to be updated there. Almost 62 clinical trials and RCTs available there for you. And the organizations are also changing their tune a little slowly. Over time, the recommendations are agreeing with the therapeutic carbohydrate restriction. And basically, more studies, systematic reviews are being published that are showing that more than 6 months adherence is helpful in diabetes reversal. So a ketogenic diet and metabolic parameters are noted to be improving, and then compared to the low-fat diets. And obviously, there's increased improvement in metabolic biomarkers with 10. If in people with diabetes, there's 10 times increased cardiovascular risk even in females, and 6 times if insulin resistance, making the case for more use of LPIR. Is a lipoprotein insulin resistance score that is what I routinely use in my clinical practice to check on the patient's metabolic health. So westernized diet, like we discussed about, is causing the inflammation, and the potential mechanism for inhibiting that is very much necessary. This inflammation is relating to converting this whole process of M1 to M2 macrophages are reduced in inflammation. There is a reduced adipose. There is obviously with high adipose dysfunction, there is hypertrophic growth, and there is fibrosis, there is metabolic inflexibility, hypoxia, and there is impaired thermogenesis. So what happens with dysfunctional adipose fat is there is free fatty acids, there is NASH and NAFLD, and type 2 diabetes causing hyperinsulinemia, dyslipidemia, all the atherosclerosis problems. And type 2 diabetes is an inflammatory condition, and there is also new therapeutic potential options being looked at. But if you see here, the NLRP3 inhibition, all these MABs and all these immune inhibitors are coming out. But if you see, all of them act through NLRP3 inflammasome, which beta hydroxybutyrate acts. There is reduced oxidative stress in aging and inflammation, and it also blocks the inflammation. If you see here, the genes are influenced by the beta hydroxybutyrate here, and then HDAC is inhibited. Basically, when this happens, we need to understand that histone deacetylase controls most of the inflammatory or expression of genes, or also in cancer, there is a significant influence of that. So next, we need to go and fast because of time, but beneficial effects of Mediterranean diet is noted within. There is an 18-month trial where they showed that Mediterranean diet reduced Mediterranean diet, that is low carb diet, decreases hepatic fat more when compared to the other diets. So this is a significant study where they showed that dietary carbohydrate restriction improves metabolic syndrome independent of weight loss, wherein they in the low carb, moderate carb, and high carb diets, they showed that saturated fats are reduced in low carb, and whereas there is another molecule called this is a palmitoleic acid, wherein that is reduced also in low carb. So it gets deeper a little bit here, but just quickly, this SCD1, which is steroid coenzyme desaturases 1, is needed to shunt the fatty acids that are produced either towards storage or burning away. So basically, this is influenced by what we eat. The more the carbohydrates we eat, the more the SCD1 is stimulated to store the fat. So basically, SCD1 is believed to play a central role in directing where the lipids substrates go. The objective is inhibiting SCD1 so that to shift the flow of carbons from storage into oxidation mode. So basically, also we need to understand that continuous glucose monitoring is going to change the healthcare paradigm with the time in range that is going to be monitored. This was a time in range study, but also we need to understand that the glycemia, even in pre-diabetics, this was a study showing that diet improved with shift to Mediterranean diet. In this Mediterranean diet, there is a glycemic control, and this was a machine learning algorithm that was used for this study, wherein the blood sugars were controlled. But even before that, in March of 2005, if you see here, this was a study published by Gunther Borden showing that low carbohydrates affect the blood sugar level and improve the insulin resistance in obese diabetic patients. So the carbohydrate restriction works promptly in diabetics. So this whole complex process is also controlled by different approaches in obesity medicine. There's multiple self-directed pharmacotherapy, and all these medications that are available. Obviously, metabolic surgery, but we have to understand that metabolic surgery improves all these complicated chronic disease factors. But this can be done using insulin resistance that can be improved with therapeutic carbohydrate restriction, a very low carb diet, and weight loss surgeries. And also, basically, the processes are similar, and the mechanisms are similar to improve insulin sensitivity, and the biomarkers do improve. So very low carb ketogenic diet in patients who basically a low carb ketogenic diet are shown to be a valuable tool in management of type 2 diabetic patients. And um, basically most of them stopped the medications in the low carb ketogenic diet. So what are the mechanisms by which therapeutic carbohydrate restriction works is mostly because patients become satiated, so there is calorie restriction automatically, and body fat is reduced, carbohydrates reduced, and ketones start burning, and they are positive in as I discussed earlier. So how to maximize is maximize nutrient density, minimize glycemic impact, and keep the insulin pulsatile. So we don't have to eat consistently to continue to stimulate insulin, but only minimally we stimulate it. And specifically, diets minimize it by increasing protein, dietary fiber, and obviously fasting, and avoid snacking and building muscle. If you see here, this is a complication of high insulin with increased carbohydrate, but with this technique, you can reduce the insulin stimulation. So the conscientious report of diabetes for remission is less than 6.5 of hemoglobin A1C, but for 3 months. And basically, these are the studies that were showing that remission of diabetes is possible. And obviously, we need to understand that de-prescribing is where the money is. We need to assess, we need to plan, communicate, and review, and that's where the whole money is. And then obviously, insulin resistance has significant cardiovascular complications, and this is a complex mechanism that we don't have time to discuss. But T cells augmentation in COVID, this was a study that was done wherein this was an opinion piece for COVID. But what I wanted to show was that when mice were put on significant nutrition, ketogenic nutrition, they stimulated gamma delta T cells, protecting them from influenza. This was an opinion piece that we published earlier, but earlier in 2020. But also we need to understand that microbiome is significant, and it's going to change because germ-free mice, there is production of less microbiome changes, and that is causing problem with wound healing. So and also the gut changes happen with ketogenic diet, with TH cells that are reduced, so inflammatory pathways are reduced. The process is simple. The nutritional ketosis is thought to be complex, but all we have to do is limit carbohydrates, aim for protein, and basically put people into nutrition ketosis and guide them through this process. But it can only be done with software, data-driven approaches, and cut carbs, prioritize approaching, eat only when you're hungry, and use fasting. And these are the techniques that I teach my patients. And barriers are simple: lack of support, inadequate training, belief system, and there is significant problems with initiating the process. And the process is simple. Anytime you are increasing the carbohydrates more than 25%, you are not helping the patient getting to therapeutic carbohydrate restriction. And obviously, the level, it depends upon the liberal or strict keto or strict low carb that you want to follow. Evidence-informed medicine is lacking in wound care, obviously, but also when it comes to nutrition, it is very hard. We need to collect real-world evidence. We have to have adequate documentation. We need to target the future solutions with N equal to 1 solution, with waist to height ratio, fat mass evaluation, triglycerides to HDL ratio, which is a pseudo marker of insulin resistance. Use Kraft testing, which is glucose tolerance with insulin testing, and personalized wound care has to be done. And that's where the nutrition targeted has to be. So the model right now is hard with the healthcare and model of the Swiss cheese model. We have to build a metabolic barrier. Modification of this for COVID, I did just to show that we cannot fix healthcare unless we fix health. We can't fix health unless we fix nutrition. And that has to start with each one of us. We cannot be this blind professors trying to solve this, and we cannot have an ostrich in the head sand approach. So key takeaway is nutrition and addiction are the things that are a problem. And remission of chronic disease is possible through various food first approaches. And nutritionally educating physicians is an important thing, and whole foods approach is a must. And non-communicable diseases are the pandemics of chronic disease in slow motion that do influence outcomes of other infectious diseases. And this game has to stop. This end game of medicine has to stop. There's no magic pill, but obviously therapeutic carbohydrate restriction in wound healing is helpful. And also we need to avoid mass medicine mindset. We need to personalize solution. We have to figure out and see if M3 versus mass medicine mindset versus N equal to 1 medicine. We just have to do it, monitor and taper and treat accordingly. So knowing is not enough. We must also apply. Willing is not enough. We must also do. Thank you very much. Looking forward to the questions, and we'll post this video later. Thank you.